for the introduction, and thank you all for coming. I know you are as excited as I am to hear about futility. It's a very exciting topic. I'm sure it helps that there's lunch here as well. So just so you know, the way I usually work is, and I think this is important in ethics in general, it's not enough just to impart information. Facts and content is not like possessions, which you can put in your pocket, because usually when you look at facts and information as something you can put in your pocket, we tend to have holes in our pockets and drop them very quickly. So I want to look at this talk on futility more in terms of looking at futility definitions, futility, how to talk about futility conceptually, operationally, and think through the concept so that it sticks more than just talk about the concept at you guys so that it doesn't. Just to get a few things out of the way, with regards to the learning objectives, after the talk you should be able to do the following. If you don't, please let me know. It means I didn't do a good job. You compare the different definitions of futility, evaluate the benefits and detriments of different definitions, determine situations in which medical care is futile as per the different definitions, discuss the disagreements that occur around futility and strategies to mitigate them, and embrace the physician's responsibility in determining when treatment is non-beneficent and its importance in patient care. With that said, here's the difficulty that I have with regards to futility. There's a lot of literature about what futility is, how to discuss it, what the responsibilities are. But while I was going through all the research on futility, I felt somewhat that I was going on a bit of a fool's errand. And the reason why I was going on a fool's errand is because it seems as if futility, even though we look at futility as a particular instance of how do we deal with questions of withholding care, withdrawing care, really what's at stake in these discussions of futility are what are the demarcation lines between physician authority and patient autonomy. So we talk about futility, but really we're using futility to talk about a much broader conversation about what is physician integrity, how do physicians relate to patients, what are the patient's expectations of physicians, and what are the patient's responsibilities or accountabilities in determining their own care. And we see this. We learn from medical school and in our continuing education about shared decision-making. It's a key component of our patient-centered care. It's a process by which clinicians and patients work together to make decisions and select tests, treatments, care plans based both on clinical evidence. They balance the risk and expectations of outcomes, and they include patient preferences and values. Right? It seems that shared decision-making applies to all questions or all aspects of healthcare, futility included. Does that make sense? Oh, by the way, when I meant like to have this be interactive, I wasn't like being humble and stuff. Like I actually expect you guys to give me as much information as I'm giving you. So in terms of patient-centered care, is futility somewhere marked out of that?
Futility is something that comes up every day, quite frankly. And the most common setting, that I'm sure you'll address it, a healthcare proxy says, we want to do everything. And the doctors say, it's not going to work. Mm-hmm. It's futile.
Okay, so this is really what the case is, right, about futility. It's not necessarily about shared decision-making in terms of looking at the efficacy of treatment or not. There's something else that's underneath that conflict that you're having that relates to not necessarily will this intervention work or not, but a conflict between patient and physician in terms of their roles, their goals, and their values, and so forth. And you can see, and hopefully we'll look at futility analogously to two other areas where there's exceptions in the shared decision-making model. And if we could see this underlying reasons for these types of exceptions, it may be able to help us figure out how to communicate when we deal with questions of futility as well. So just to throw out there, if anyone wants to take a guess or venture, what they might think. What are the two exceptions in shared decision-making where physicians have a lot more authority in the decision-making process?
The physician can refuse to provide care that is futile.
Yeah, so besides areas specifically of futility.
Life-threatening emergencies.
So interesting. So life-threatening emergencies, and this, I was going to say maybe there'd be three, but then the reason why I'm not putting life-threatening emergencies there is because a lot of times when there's life-threatening emergencies, we rely on a concept of presumed or implied consent. So even if the patient is not explicitly giving consent or implicitly informing the decisions to be made, there's enough contextual or circumstantial type of justification to say, no, the patient would agree to this. That's the reason why they're here in the first place. We're still acting in the best interest. There's not a conflict of values there, right? So the two examples that, yes. Okay, so I'd put that in a broader category. So I would say when patients are incompetent, or in certain cases of pediatrics, right? Both of those cases, I'll start with pediatrics. Pediatrics, we have this idea of pediatric assent versus parental consent. And the doctor's role with regards to pediatric consent is not to really have shared decision-making with the child, but basically try to see the child where he or she is at and educate as much as make decisions, knowing that the child or the compliance of the child will be much more effective or productive if they feel like they have a stake and are involved in the process and identify with the decisions that are being made. However, despite the fact that you have the parental consent is the real force behind pediatric ethics, parental consent is really not just, or really not in the same vein as patient autonomy as we typically see it in these types of conflicts, because when parents make decisions that are not in the best interest of their children, then there is an overriding authority or an overriding power that the physician can exercise in order to act in the best interests of that child. Right? The state uses the term parens patrae. We use the term physician integrity and our fiduciary responsibility to our patients. Right? Incompetent patients are actually very similar. Right? Incompetent patients don't have the decision-making capacity to engage in the same types of decisions as we have in pediatric ethics. So we either use a substituted judgment standard, or we use proxies who are not making decisions for the incompetent patient, but are in terms of imposing their view onto the patient, but they're using or they're trying to investigate or elucidate what the patient would want. Right? But in those situations, when the proxy is not using substituted judgment, or they're using their own values and beliefs and imposing it on the patient, or they're acting not in the best interest of the patient, also with incompetent patients, there's a duty to not listen to the proxy. Yes? Right. So 100%. And when the court appoints that proxy, the court isn't making the decision for that proxy based on what the court wants. They're still trying to investigate, and they'll use either subjective standard, substituted judgment, or best interest standard, depending on the information that they have. But they're still trying to say that there's an underlying presumption of what the patient might want. They just can't exercise it at the time. Right? So, still, even within these, in these two, when there's exceptions, it's not necessarily because the patient wants something and the physician wants something else. It's that there's a miscommunication of what the patient actually wants. I'm not saying that's exactly futility, but hopefully we can use these two examples to start thinking about futility. Yeah.
About communicable diseases, we frequently do things directly opposed to what the patient wants.
Right. So communicable diseases, and when you have public health concerns, yeah. So I'm not sure how much you want to tie that analogy to questions of futility, even though you might say, no, look, questions of futility also have to deal with, population and resources and stuff like that. The difficulty with looking at it that way is the AMA Code of Ethics is very clear that rationing and considerations of resources shouldn't inform one's decision of futility. Now, there's a confused conception of utility, I think, in the AMA, and we're going to go through that in terms of how they're conceiving both substantive definitions and the process-based definitions. But when you start saying, no, futility is like communicable diseases, either with regards to duty to report or going against their decision, going against what their autonomy is, you're broadening it to include more things that might not be as helpful for the moment. But I hear you. That would be like a secondary type of analogy I would want to make. And by the way, the reason why I'm making these analogies, as opposed to saying, no, let me just give you direct definitions of futility, or let me just give you a direct analysis of futility, regardless of what any of the other topics that have to do with healthcare might relate to, is because a lot of times when we think about clinical decision-making, or even more generally, prudential decision-making, it's not a matter of taking a normative premise, a set of facts, and then just looking at it like a key in a hole, right? A lot of times we look at cases, see what's similar, see what's different, see how we can apply underlying commonalities and themes. It's not that type of, black letter law applied to reality. So if we can anchor futility and the question of futility and how it relates to shared decision making with some of these other analogies, it might allow us to think about how to communicate futility in a little bit different way. Okay, so when you look at pediatrics and when you look at the incompetent patient, that conflict, there seems to be mechanisms and there seems to be policies and procedures that really work well in terms of the physician having confidence of this is what needs to be done, this is what we should do. The controversy, the struggle is not as difficult. Futility seems to be very different. Right? Even though they conceptually seem very analogous, all of a sudden when you talk about futility, there's something else that's happening that makes these conversations so much more difficult and make these procedures so much more difficult than in the case of pediatric ethics or an incompetent patient. What is that? Any guess is good, because at least we can start with the frame of reference of something as opposed to nothing. Okay. 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 So I'm going to rephrase both of those suggestions because I think they both hit on something. The first is, if we're talking about the second one, the stakes are seemingly much higher with futility than in incompetent patients and pediatric patients. Pediatric patients and incompetent patients, generally, we're on the same page, or the physician expectations and the social expectations are much higher in terms of, we want this person to be healthy and alive. Where futility, what's at stake is life and death, and it seems to be that the caregiver or the person who has a fiduciary responsibility is on the other side of that value. Right? The second is that with regards to pediatrics and incompetent patients, the presumptions or the definitions are less ambiguous. Right? Even when you're talking about values, they're more generally accepted in terms of not only the conceptual, but the operational definitions of what this exists. With futility, there are many definitions, and now definitions don't really apply anymore. So how you talk about it, you may be saying one thing, and the patient may be hearing something very, very different. So like even in terms of communication, the words that you use no longer have the same efficacy in futility than they would have anywhere else, especially because today, where patients are being more and more involved in directing their own care, you use words that are very professional or profession-based that look very different in the patient's view, right? And if you see this, and if you realize this, you can see that when you, before even going through all the major definitions and so forth, when you look at the empirical studies about futility, the academic literature on futility, whether they are for, it sounds so silly, but for or against futility, right? The presumptions or the underlying theme when they talk about, or understanding when you talk about futility, is always going to be physician-focused, right? And I don't mean physician-focused in terms of we should focus on what the physician should do. I mean physician-focused in terms of the physician is defining and determining what futility is. Then let's talk about it with the patient to determine how to move or how to act and make a decision. Right? And by the way, I'll give you a really simple case, and you could see what I mean by physician focused. So let's just take the most general definition of futility that we can find, something that doesn't achieve the goals of action no matter how often repeated. That doesn't seem like it has anything to do with medicine. That's just a general definition. By the way, do you guys know how futility, like where the term futility comes from? It's like the same idea of having, what is it? It comes from this, the metaphor of the leaky bucket, right? Like in Greek mythology, two women were cursed where they had to fill up this tub with a leaky bucket. And as they filled up the water in the pail and tried to put it in the tub, all the water would come out, right? So that had nothing to do with medicine. It just had to do with, achieving one's goals. So let's say something that cannot achieve the goals of action no matter how often repeated, right? Take a case of a person who is at their end of life, and they want everything done, and they tell you, I want you to spend all my money on healthcare, because you know what? I hate my kids, and I don't want to leave it any of them to them, right? Spend everything. I'd rather have 6 weeks left enjoying my hospital bed than have my kids enjoy for the rest of their lives without having to work. Okay? Would we consider that futile care? All right, let me rephrase. Do we think spending healthcare resources, even if the person is paying it themselves, but for the intention of wasting it so they don't have to give it to their kids, a futile treatment? I mean, let's just call a spade a spade. It's a waste of everybody's time. Give the money to charity. Give the money, do something else with the money. Right? But it's not futile to them, right? But would we have integrity by saying, yes, the patient's always right, and we want to spend our resources, even if they're paying for it, and spend our time and our expertise repeatedly performing behavior that fulfills that patient's goal of action?
Following this.
Oh, no, 100% disingenuous. Yeah. Right. Mm-hmm.
They're likely to want to stay alive. They want to have a life. They value it differently.
Mm-hmm. Right. So I'm really glad you brought this up, because what I think that you're doing, and I think needs to be done. Oh, just to repeat, did everyone hear? Okay, so what was your name again? I'm sorry. Dr. Wolf? So, what Dr. Wolf said is, no, even though the patient is saying, waste my money, what the patient is really saying is, I'm angry, I'm telling you to waste my money, but what I really think is that I value life and I want to live a little bit longer. Right? Even though the patient never said that, we're assuming that the patient is saying that, because otherwise they could have just given their money somewhere else, but they're asking for medical care. Yeah, no, I hear you. The reason why I disingenuously rephrased what you said was because when we look at goals in futility, we have very clear goals of what those are. And we'll force ourselves to put those goals in, even when we say patients' values and goals and shared goals and so forth. And when we mean the goals, we mean really goals that are intrinsic to the action or intrinsic to the habits of the profession. Right? So when we say a futile action is one that has no benefit or can't achieve the goals of action no matter how often repeated, those goals are really goals that are internal to the medical profession. Right? Either treatment, cure, care, or something that has to do with why you joined the profession in the first place. Not simply just to waste money or have the patient/customer always be right. Right? And to be less disingenuous, you can actually see the physician centricity of these when we talk about the future conceptions of futility, with the ethical reasons that justify withholding futile treatment. And these, I'll just let you know, I took from Barak Rodi and Alevi's article, "Is Futility a Futile Concept?" So they say the ethical justifications of withholding futile care is the treatment doesn't fulfill the purpose of medicine. It doesn't adhere to the standards of scientific competence. It can result in loss of public confidence in the medical profession, and it violates the ethical principle of do no harm. Right? So even in that disingenuous example, even as much as we may want to imply or presuppose certain medical goals that the patient might have in addition to what that patient said, we still may say that is not a good use of our time or our resources, not because the resources could be used elsewhere, but because what does that do to us as medical professionals? What is that really our purpose for why we do things? And we may be imposing harm even if we're looking at instrumental good. Right? And by the way, when you look at these ethical justifications in general, they seem really, really strong. Right? Does anyone have any issues with regards to the ethical justifications just presented? Like, are there anything like, I mean, you could say, well, do no harm is really subjective or a very difficult way to actually define, or who actually gets to determine the purpose of medicine and so forth, fine. But in general, they sound like they're pretty good ethical justifications. Right? The difficulty when you talk about futility is the general application of these goals, or the general applications of this way of thinking, doesn't always fit with this particular application. Now, I'm going to give another example, which I think Dr. Wald would also say is disingenuous, but this one I actually took from an article, so I feel much better about using it. So this one is from Michael Nair Collins, Length Utility to Rest. So Mr. K is an 84-year-old man with late-stage Alzheimer's disease. He's barely responsive and has developed pneumonia secondary to aspiration. Sadly, a bitter futility dispute has arisen with respect to his care, first involving the clinicians and family, but has since enlarged to include ethics consultants, the ethics committee, hospital risk management, and now the courts. The dispute arose because the family insists on an intervention that is, according to the physicians, a case of obvious futility. The reason why it's a case of obvious futility is there's no pathophysiologic rationale, and it is effectively guaranteed not to achieve the purpose of medicine or adhere to the standards of scientific competence. The hospital refuses to allow this intervention, yet the family insists. Right? It seems in general, many cases, that fit this, that we see this all the time, and this is a problem of patients asking for something, excuse my insensitivity, something crazy that doesn't really fit with why we're here. Right? So now let me tell you what Michael Nair Collins says the intervention is. What is this futile intervention? Mr. K's 5-year-old granddaughter has a magic teddy bear that she wishes to place next to her pop-pop because she believes it will help him feel better. Right? Again, this is a very silly concept, or a very silly example, right? But like, there's a reason why I'm pulling this, right? Because what I'm pulling is, when you look at futility, you can't really look at futility in the abstract or in general, right? You have to really look at what's really at stake here. Because yeah, putting a magic teddy bear has no pathophysiological rationale, right? It's not, it doesn't fulfill any standards of scientific competence, right? But again, oh, and if pop-pop is actually unresponsive, how much is pop-pop going to appreciate? And you can say, yes, psychological studies with unconscious patients, they may have, I'm not saying that. How much is pop-pop really going to appreciate the magic teddy bear going to be there? Right? But even if it doesn't, none of us would say, I'm sorry, my physician integrity would never allow that. It sounds crazy. Right? It's crazy. So when we look at futility, we really have to think about what actually is at stake. And through this example, through the example that I gave before, what's at stake really isn't ineffectiveness. We talk about futility as, well, if something's ineffective, it now has moral grounding to it to make a decision. Yes?
Well, that's going to be the next step.
No, 100%. Right? And so, but again, like, let's go back to putting in something that will shock a patient or hurt a patient, right? What's at stake isn't whether it works or not, but what other consequences are there, right? So I do want to get into that. Let me get to that case a little bit later, because we're going to talk about that when we talk about how to communicate with patients and so forth. Before I get there, I kind of want to talk about, okay, so where did this controversy around futility come up? Like, how did it become such an important, such a grounding controversy in healthcare? Does anyone know where, like, the first conversations around futility occurred? Take a guess. Oh, not where, sorry, when. That would be a better way of putting it. World War I? Civil War, okay. So this also, you should know by now, any question I ask, you're probably going to be right, but I'm going to like make something irrelevant, like some crazy comment or extraneous comment that says, no, 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 it's a little bit different. So futility was brought up in ancient Egypt papyri. They were brought up with the Hippocratic physicians, but like no one cares, right? Because when we talk about futility there, it really has nothing to do with the controversies that we have today. Right? It means in good clinical practice, don't do something that like is trying to fill a tub with a leaky bucket. It doesn't make sense to do that. Yes. Mm-hmm. Yeah, so I was going to talk about the legal, and I was going to actually go into malpractice. I can take it aside and just answer that now if you want, and then go back to this. So look, when you look at malpractice, malpractice cases have a very like set type of formula to it, and yeah, anyone can get sued, by the way, for anything. Being sued and being found liable in a civil suit are very different things, right? But when you look at the formula of a malpractice case, both the plaintiff and what the defendants are trying to show is probable cause, or more importantly, if it's not battery, but in this case it might be medical negligence, is did the doctor not fulfill their duty of care by a reasonable or professional standard, right? Where does a reasonable and professional standard come from? Reasonable professional standard comes from either hospital policy or national policy, depending on what case of malpractice is, or state and regulatory state laws or regulation, right? So what's really interesting about futility is it's even not a question of what me as an individual physician versus you as an individual patient come together as a contract in terms of that type of medicine. Is what are these social and professional expectations that create what is normal or what is within the standard of care, right? So when you look at I'm afraid to be sued, or I'm afraid that the law is against me in this, the best protection against a legal suit when a case of futility and medical negligence is having really strong hospital policies that not only teach your physicians what to do, but set an expectation both for physicians and for patients of what will be done and what is considered professional standard in the hospital or in the emergency department, right? Once that is set, it's very hard to say that this doctor didn't do what this patient wanted, because it's never in the law about individual doctors or individual patients. It's about the reasonable person test or about the professional standard test. And the professional standard test is never about what an individual patient expects, but what the professions in their policy statements, hospitals in their policy statements, physicians as I want to say, those physicians, and I mean like the profession, not individuals, who inform the state or the courts or the civil courts what is the practice of medicine, what the expectations are, right? So when you don't have these policies and you don't have clear expectations, yeah, futility becomes even worse. Because now it's a matter of saying, not only do I not know what to do, but there's no expectations either way of how to follow it. So these types of conversations are now doubly confused, because not only do I have to worry about what the patient expects, but I don't even know what my colleagues expect. So I'm going to be very defensive and do everything, because it's easier to err on the side of life than it is to do otherwise. So, all right, let me go back to futility. So the concept of futility really started coming in the 60s and 70s, and really in the 80s with the rise of patient autonomy. Patient autonomy started with the right to refuse treatment, and quickly changed to the right to demand treatment and the right to be involved in the direction of one's own care. So as patients took greater hold or greater reign of what this clinical decision-making path would go, physicians realized that there has to be certain circumstances or certain situations that it's not just enough, or it's not right to do just what patients want, but we're the ones who spend the time being trained and understanding clinical situations where sometimes we still do know best, physician paternalism is not simply about power, it's also about authority. And where that played itself out was in debates on futility, right? And you could see this tension between physician authority and patient autonomy being played out in the AMA's Code of Ethics that discusses medically ineffective interventions. And I'm just going to read the paragraph, and then you could see how the tension is still there. It's still I want to say a tad confused, or even if it's clear, it's hard to work with. Physicians should only recommend and provide treatments that are medically appropriate, i.e. scientifically grounded, and that reflect the physician's considered medical judgment about the risks and likely benefits of available options in light of the patient's goals for care. Physicians are not required to offer or provide interventions that, in their best medical judgment, cannot reasonably be expected to yield the intended clinical benefit or achieve agreed-upon goals for care. Respecting patient autonomy does not mean that patients should receive specific interventions simply because they or their surrogates request them. Right? That's a lot of words. It's a lot of words. What does that mean? Clinical judgment is still allowed, yeah. So, anybody else want to? Yes, please. Mm-hmm.
And patients fear us. And anything here I can discuss about patients. Pointed out to me about and so in every other aspect of our practice, we don't offer something that's not medical. And the truth is, the autonomy, patient autonomy, never really been about patients in demand care. Patients may have understood it, but it's never really been patients in demand. We don't, this class is there, we don't have a but where we have a law for one way. And so we demand that. But the point is, no physician would do that.
Yeah.
But just because somebody wants something doesn't mean that you're
Mm-hmm.
I think I have a better.
Sure.
Somebody who understood. Obviously, they get that money.
Mm-hmm.
Also, later we come out with what they said for me, it's going to have royal for me, because that's I don't think it's what he wants to come to the Africa for whatever next period of time. And he's going to pay out of pocket.
Mm-hmm.
Patient has been sold 3 years ago also. He's not going to get any functional recovery. Obviously, there is no indication to bring that patient to the Africa. But that's his body. And he has a hope that by doing that intensive therapy, he might get functionally better. We cannot bring him over, accept his patient while we are taking care of him.
Mm-hmm.
But who am I to deny him when I could not take him?
Right. So only because I have to get to my learning objectives of defining different definitions, both of those examples actually cut to a crux of how to talk about futility with patients or medically inefficient or medically non-beneficent care. So let me just go through the definitions and then get to how do we talk about these, knowing that those two are really the kind of cases that are at stake. So if you look at the definitions of futility that come up, it's funny, a lot of them actually are derivative of Pope Pius's distinction between ordinary and extraordinary care that he came out with in the 50s. But there's a very major difference between them. So when Pope Pius came out with ordinary and extraordinary care, basically ordinary care was anything that fit within the realm of medicine, both in terms of the goals, in terms of the costs, in terms of the reasons, and so forth. Extraordinary care was either something that the burdens did not or overrode the benefits. It was incredibly expensive, which then put a pressure on the community. It was dangerous, It was painful for the patient, and there was no reason to have that patient undergo that type of extraordinary care. Even if one could foresee it as an instrumental good, the instrumental good still was not deemed to override the harm that it would cause. The difference, or what Pope Pius put on in terms of the ethics of ordinary and extraordinary care, which is not something that really related in the same way to futility, is the ordinary and extraordinary care was not only a distinction that was put on physicians, or what do physicians have a moral responsibility to offer, but it was put on parishioners, meaning a Catholic patient should not ask for extraordinary care because it showed a certain lack of moral responsibility, or a lack of faith, or whatever it was. It was the normativity of this distinction was equally shared by physicians and patients. Futility is not equally shared by physicians and patients. Futility is not a question of, I'll put it this way, patients rarely put themselves in the question of, is this intervention, I want it, is this intervention really worth it? You know, unless that conversation occurs, but that's not something that they're going to, before they even demand care, that's like, they would say, doctor, I've considered it. I understand that you know that this may be conceived as an extraordinary, but I still reconcile this with my prudential analysis. You know, that's not, like, futility went from being something that was on a community to now being a definition that was used with normativity, but really a descriptive definition for doctors. So the different definitions, just to go through, and then I'll talk about the communication part, is qualitative futility. So qualitative futility, or the qualitative approach, basically looks at if a treatment is more burdensome than beneficial. Right? Now, the burdensome versus beneficial is not necessarily about is the intervention itself burdensome, but the results of that intervention more burdensome than beneficial. So that's a very difficult subjective type of definition of futility, especially because you're looking at quality of life, which, as empathetic as we may be and as able as we are to get into the shoes and the minds of our patients, we still might have our own biases to realize what our quality levels are versus what their acceptance of quality is. The second is the quantitative futility. The quantitative approach considers the probability of effectiveness. Right? So some medical ethicists argue that it should be 1% is a line, some say 5%, but the quantitative approach basically is, will this actually work or not? Right? The strict physiological approach is your teddy bear. Right? Then you have two others, lethal condition futility or imminent demise futility, which basically says, are we doing this? Why are we doing this? We know the patient's going to die. What is the point of maintaining the extra quantity of life for what purpose and so forth? Also has some subjectivity to it, but not in the same way of the quality of life thereafter. It's not a qualitative state. It's a quantity of time. Right? All of these approaches, even though we still might use them as heuristics, have been basically rejected by the AMA. And the AMA and many states have now offered a process-based approach. And I'm just going to quickly read the process-based approach because it's long, and you'll see why I'm reading it as opposed to telling you. As clinicians, when a patient or a surrogate requests care that the physician or other members of the healthcare team not judge to be medically appropriate, physicians should, number one, discuss with the patient individual goals for care, etc. Reassure the patient that the medically appropriate interventions will be provided unless the patient declines particular interventions. Negotiate a mutually agreed upon plan of care consistent with the patient's goals and sound clinical judgment. Seek assistance from an ethics committee if this doesn't work out, or seek to transfer care to another physician or institution willing to provide the desired care. What's the problem with this process-based approach of the AMA? So number one, the patient may die before it goes. Mm-hmm. So patient may die timing-wise. You can't do anything by committee, especially in a high-stakes environment. What else? If I told you this was the AMA process-based approach for shared decision-making, that should be at the introduction of whenever you take a social history for a patient. That would make sense. But you're at a stage where the patient is saying, I want to try this, or I know this might not fit with what's usually done, but I heard about this new treatment, and I'm at my last legs, and I'll try anything. Is that the time to start talking about patient goals? Like, does that actually, like, I mean, just think about it, how, like, the anxiety and the stress of that environment, is that actually going to happen? Right? Well, I'm seeing some heads shaking no. Does that mean everyone else who's not shaking no says, yes, that is exactly when it's going to happen? Well, mm-hmm. Mm-hmm. No, 100%. Right. So what I'm taking from the AMA process is this is really difficult to do. And yeah, you should talk about goals and as they continually change. But in that manner, it's very difficult to actually have what's at stake with regards to futility. Right? So when you realize that when people are asking, or when physicians are reluctant to provide that type of care, and when patients are demanding that type of care, it's not really only about, or primarily even about, the effectiveness of the treatment. Right? There's something else underwriting it. Either we feel very uncomfortable harming the patient for no reason, we think that the surrogates of the patients might be disingenuous, or taking advantage, or are so wildly inappropriate that they may not even understand what the purpose or the consequences are of what they're asking. Right? So when you think about it, there's three questions that you can think about how to frame a medically non-beneficent request. Is there a dispute about what, in fact, is the true efficacy of a given intervention in light of administering it? Like, is the belief that the patient thinks this will work when the physician thinks it won't work? That's one type of conversation, right? And the patient should, or hopefully would, rely on your authority and your experience and your knowledge to know that if it works or not, right? So it could be a question about the efficacy itself. The second could be, is there agreement about the efficacy? Like, both knows that it'll work or not work to a certain degree, but the disagreement is what that dividing line is between, is it worth it or not? Right? Like, the patient and the physician might agree that there's a 15% chance that this will work. The physician says, no, anything below 20% we don't want to do. And the patient says, anything above 10% I'm willing to try. That's a different conversation than this is not efficacious or not. Right? The third is, and going back to what Dr. Wald said, is there a dispute about the appropriate goals of treatment for this particular patient, or the appropriate goals of healthcare more generally? Right? This gets a little bit more complicated. Right? But again, if you recognize which one of these three questions you're actually trying to have a conversation about, it makes it much easier. Right? Because the question is, if you're looking at the appropriate goals, a patient may say, I understand the effectiveness. I understand that the effectiveness doesn't really fit with what is hospital policy, but my daughter's graduation is in 2 weeks, and I'm willing to take a chance for 2 weeks, as opposed to saying that this will actually cure me. Right? Knowing what those goals are now has a very different definition of, well, what is considered futile and what are the goals shared between patient and physician, and what the results are. As opposed to a person saying, no, my goals are, at this point, go back to the person who wants to waste all their money, I just want to try anything because I have ulterior motives. Right? Or when you're talking with surrogates, there may be something different where having questions about futility with someone who advocates for a certain position, which doesn't seem to match what the patient has always, or what the patient's values have been previously. The question there is not about futility anymore. The question is about, is this really what the patient and the physician have agreed upon or continually negotiate in terms of what the goals of care are, right? Some things that we need to be careful about when we have these types of ways of looking at it, ways of communicating it, are patient and physician biases, right? When you look at appropriate goals, it's difficult to take one's own biases of quality of life outside of the frame of reference and really understand what the patient's quality definitions are. But when you talk about, well, this intervention will give you this physiological consequence, when the patient isn't caring about that physiological consequence, but they're caring about this social experience that they may make or miss, right? Directing the communication to what is at stake for the patient might make it easier to get out of your own biases and into theirs. The second is, and this is so pithy, I feel like we all know this, but it always needs to be said, futility is not about care. It's not, right? Futility is always about treatment, right? Because a lot of times, and this goes back to patient biases, sometimes when surrogates or even patients want everything, it's not necessarily about efficacy either. It's about they don't want to lose hope, or they don't want to show that they don't care, or they don't want to feel abandoned. So they say, give me something so I don't feel like all is lost, right? So futility should really be focused around questions of treatment, not interventions at large, where care is a different type of conversation to have. When you break all that stuff out, right, then the controversies around futility really become minimized because the breadth that futility, or the confusion around futility really then narrows, because everything else could actually be part of a conversation of shared decision-making as opposed to what happens at end-of-life care when there's conflict. So we have a couple minutes. Does anyone have any questions about the entirety of what I just said? So great. So, oh, yes. That's really tough. And the reason why I want to say it's really tough is because everywhere is changing a lot. And what I mean is, even in the Western world, futility is changing, let alone elsewhere. And I mean because religious values are on the rise. So the idea of quantity versus quality of life is becoming very changed. Even if the way medicine is practiced is truly Western, regardless of where you are. In the West, in places where, forget the religious conflict, the idea of patient autonomy controlling when one dies, not just the decisions that one has, even the legal presumption that to err on the side of life is not a harm is changing now also. Like when you look at the idea of suicide and physician-aided dying, it then looks at futility no longer as patients want to always do everything, physicians want to make sure that they stay responsible. Sometimes it's kind of like the reverse. So these questions of futility in general, you can't say, are they changing in the West versus this? I think they're a flux everywhere. And the reason why they're a flux is because the history of the concept of futility came through a certain moments of the rise of patient autonomy, given certain patient preferences, and those patient preferences are now changing. So futility, the notions of futility have to change as well. Does that kind of not answer your question? Yeah, so it's hard to say. Honestly, I can't really say. If you want, I can do a little bit of research and get back to you. Yeah. Did you have? No. Yes.
Something we didn't talk about, which I think is very important every day, is that I think most of us know things are futile, really don't want to do them, but the unbelievable hassle factor of not doing futile things would make your life as a physician impossible. So we were talking about lawsuits before. Most of us don't care if we lose a lawsuit. We care if we have to be involved in the lawsuit. Because that's going to take 100 hours of our time, $1 million of our time. It's just not worth it. And similarly, to have these conversations with families, go to an ethics committee, and then go to court, that's like a month of work when we have a lot of other things to do.
No,
So
100%.
far, the easiest thing to do is just say, you know, I don't agree with you, but fuck.
Right. So that is a really great point. I'm glad you brought it up, and I'm glad you brought it up with only 4 minutes for me to talk about. So that, look, you hit on two major issues. One is what is it called? The obstacles that a person confronts in moral action, right? It's easy to make an ethical decision. It's really hard to carry it out, right? And by the way, it's the difficulties in carrying it out are not only because of a person's own disposition. Organizational barriers, legal barriers, cultural barriers are valid and should be recognized. That's why the AMA, even in this non-medically ineffective care, which I didn't read, it includes, after it talks about the individual, it says, as leaders within the institution, physicians should encourage the development of institutional policies that do A, B, C, D, and E, right? Because if you're the only person doing something that's right, you will no longer be doing that thing. It just won't happen, right? The second thing is, even with organizational help, and let's say you have all the benefits, it's still difficult as an individual dispositionally to do something. But it's difficult in any decision that you're going to make in healthcare, even if some of the stakes are larger or smaller. One of the things that I try to teach the medical students, which I find helpful, is there's different ways of approaching ethical questions. There's the ethical question of what should be done. But then once you say what should be done, there's a moral gap between what should be done and what you're actually going to do, right? There's a different way of saying it, or a different question you can ask is, if I wanted to act on my values, how would I go and act on them? And what would be the best way to do that, right? So then your question of, yeah, I should withhold medically ineffective care, but, and give all these rationalizations. Another way to think about it is say, if I wanted to act on my values of physician integrity and make sure that I did not provide care that I didn't think was worth providing, how would I go about doing that in a way that the patient understood, the patient accepted it, the patient wouldn't feel like there was a rift in our relationship and continued to trust me, and accepted the finality of their position, regardless of whether I was going to involve that care. Right? If you looked at it through that enabling stance, you may be able to find ways of having those conversations that actually get what you want, as opposed to justifying saying, well, even though I should, I can't do it anyway. No, 100%. You should. I mean, that's what I spend my life trying to teach that. So, yeah.
But one of the big problems also in research, that's why the dynamism of the dilemma is also with the internet.
Mm-hmm.
If there's another third person, you have the patient, their family, and you have the physician, and then whatever they get from the internet may be fake.
Mm-hmm. No, 100%. So that's what's really interesting.
More complicated.
Right. So we teach our medical students about how to deal with questions of when their patient comes in and says, oh, I found this great fast food diet that I think is really going to be help me with my whatever diabetes. We teach them how to talk to patients when they get crazy stuff off the internet that doesn't make sense, and that is part of shared decision making. You have experience, you have authority, you have knowledge. How do you impart that onto your patients? But all of a sudden, when it comes to futility, all of those skills that we learn when the stakes are much higher, or the stakes are much lower, no longer apply. That I think actually has to do more with cognitive load than it does with something that's qualitatively different. We can do it when the stakes are much lower. It's very difficult to do it when the emotional stakes are much higher. Yes. This will be my last question.
Also, just like we pointed out, besides that, you got people like Dr. Hans
Yes.
giving at times crazy things, and he's been disciplined by the FDA, he's been disciplined by the American College of Cardiology, etc.
No, I agree with you. Yes. So, all right. Well, thank you guys very much.
Also, I wanted to say this is the last week of the sub-interns. I don't know if any of them are here. I wanted to thank them for their work. Congratulations. This is the last rotation in the 4th year. But thank you. Also, our 3rd-year students are leaving, and I want to wish them all the best of luck. I think this is their last formal day today. And I want to thank the BEDUP for an outstanding presentation.
Oh, I'm telling you about that. Thank you very much.
Wonderful.
you.